All right, Daniel Clausen, Tad Baird, I see you in here. Um, Introducing you to Dr. Jim Frame, and he's your lead medical director. I'm here to talk to you tonight about EMS and sepsis management. And since it's just a small group, if you have any questions or comments, here comes Ashley Arredondo. If you have any questions or comments, just unmute your microphone, ask your question, and then you can remute your microphone afterwards to keep the ambient noise down. But I think with a small group, that will work fine.
All right. And do you think with the small group that we could see all their videos, or is that possible?
It just depends, because it might be too much for any one of them that may have a slower bandwidth. Then everybody's videos running would probably drag that person down or even knock them off. So it's probably better not to.
Yeah, fair enough. Okay, sounds good to me. All right, well, greetings, and once again, thanks for being here. I'm Jim Frame. I'm your lead medical director for the PERCOM medical program, and of course, I've seen all three is in the chat rooms before. So without any further ado, let's just get started. Give you a background a little bit, and maybe somebody else will join in so don't miss anything, but let's give you a little background. We're in cycle 5 now of the National Registry EMT exams. Those kicked in October 1st. Subsequently, there's an emphasis on the top 5 diagnoses that are going to be tested, or at least emphasized on future medical emergency sections of your paramedic curriculum. And one of them, of course, is pneumonia. That'll be the shortness of breath and difficulty breathing patient with a high fever. Could actually also be the HIV patient or the patient who has just been released from the hospital. So you're going to see pneumonia in one of 3 scenarios. The alcoholic patient, the patient who has aspirated in a nursing home, and the patient who has HIV. Now, in all 3 of these patients, I think you can see that there's an immune compromise component to them. So what will happen is the patient will have a classic presentation of cough, congestion, shortness of breath, fever, and there'll be something in the history that's going to clue you into pneumonia, such as recent hospitalization, nursing home patient, HIV status positive, or chronic alcoholism. So be alert for those 4 flags. Now, the second condition, the first one being pneumonia, the second condition is going to be diabetic ketoacidosis. And the ketoacidosis, in any ketoacidosis question, you're going to see a glucose range between 350 and, let's say, 700. Above that, you're probably not diabetic ketoacidosis. At that point, you become non-ketotic hyperosmolar. Those patients tend to dehydrate pretty quickly. Non-ketotic hyperosmolar patients with glucoses over 700 will become dehydrated. As a result, they'll have tachycardia, but most of their respirations are going to be rapid and shallow, consistent with a shocky state, low volume dehydration state. Whereas the diabetic ketoacidosis patient's trying to blow off ketones, and the ketones are causing acidosis, whereas in the non-ketotic patient, they don't develop acidosis. So watch for the deep, rapid breathing, the so-called Kussmaul respirations. Those are going to be deep and they're going to be rapid, as opposed to the non-ketotic, which will be shallow and rapid. The key here is to recognize, when you do fact pattern recognition within a question, the deep, rapid respirations are the so-called Kussmaul respirations. And that's going to be indicative of diabetic ketoacidosis. Now, of course, you can have some overlap with regular conditions and such, but these are the 2 big distinguishing characteristics between the 2. The patient who's diabetic ketoacidosis may very well be unresponsive, as well as the non-ketotic hyperosmolar patient, where their sodiums get up close to 160, 170. They could certainly be altered. But the patient who's diabetic ketoacidosis, you're going to find this fact pattern. And the fact pattern is going to be a younger person who has not taken his or her insulin over the past couple of days because of persistent vomiting and diarrhea. She hasn't been able to eat properly. Subsequently, without eating or drinking, she has not taken her insulin for fear of going into hypoglycemia, because you know that when they give themselves insulin injections, they are supposed to eat something. So if they've been taught that if they're vomiting or if they're not eating or drinking, not to take any insulin. Well, as a result of that, fat starts breaking down because there's not enough glucose circulating. Subsequently, the fat's breaking down because there's not enough insulin present to carry the glucose into the cells to metabolize. Subsequently, it gets its energy from breaking down fat. And one of the byproducts of fat metabolism is ketones. And that's what causes the acidosis. So when a patient's breathing deep and rapidly, they're trying to blow off the acid. The respiratory system is the first to try to adjust acid-base balance situations. If you're alkalotic, your respirations slow down, but most likely when you're acidotic, you start speeding up your respirations. And the deep respirations are significant for getting a whole lung full of air and blowing it all off to get off as much CO2 as you can. So these patients really are going to be emphasized on the next couple of cycles now as far as DKA. The third condition, the first one being pneumonia and the second one being diabetic ketoacidosis, the third one's going to be stroke. And the emphasis on the stroke here is going to be the Cincinnati stroke scale. And then what do you do when the blood pressure is above 200? And what do you do if the patient is having airway issues and such? You have to be able to recognize the airway issues. So the vomiting patient with stroke-like symptoms and such, they're just going to get a tube. If they're any kind of lethargic or any kind of GCS, which is 8 or less, you're going to go ahead and give a tube. The old mnemonic, less than 8 intubate, or 8 or less intubate, they're not going to give you a GCS of 8. They're going to make it very obvious. It's going to be a GCS of 5 or a GCS of 11. They're not going to give you anything close because the number 8 has some controversy around it, whether you do or don't. 7 you do, 9 you don't. So be looking for that. But the real assessment comes in is how do you handle high blood pressures in a patient who has stroke and altered mental status. And that's going to be the administration of medications that's going to lower the blood pressure. So for instance, metoprolol, any of the beta blockers, you're going to give low pressure IV to help lower the pressures and such. You don't carry that kind of stuff, then it's going to be really any medication that can lower the blood pressure. The key being that you want to keep systolic pressure from 160 and 180. And also with the stroke management, of course, is from the patient with the head of the bed of at least 30 degrees elevated. And you'll be in pretty good shape. So for the first one, pneumonia, we talked about the patients who are at risk. The second one, which is the diabetic ketoacidosis, the patient and fact pattern is going to indicate somebody who hasn't taken their insulin the last couple of days. And then the third one, the stroke patients, usually going to be the 50, 60, or 70-year-old with some sort of flaccid paralysis on one side or the other with an elevated blood pressure. And the Cincinnati stroke scale will have to be instituted. The follow-up questions are going to have to do with blood pressure reduction and such. The fourth condition is going to be sepsis and sepsis management, which we will get into here. So I'm not going to give you the lecture and then re-give you the lecture. The fifth one is really going to be concerning any type of heart issues. And their focus again is on heart. And it's going to be MI, SVTs, or congestive heart failure. And so their emphasis on the MI is going to be MONA, morphine, oxygen, nitro, and aspirin. It's going to be the proper recognition of the two types of MIs that can give you preload problems, posterior MIs, as well as inferior wall MIs. And it's going to be blood pressure reduction in the patients that have elevated blood pressures in the setting of an MI. There's also going to be some hypotensive MIs, which you usually see with the anterior wall MIs. So what would be the appropriate treatment, both from a fluid bolus standpoint as well as from a medication standpoint? We realize that many systems don't carry pressors that will help with the blood pressure. If they do carry pressors, it's not going to be the type that whips the heart, such as an epinephrine drip or a dobutamine drip. But Levophed or dopamine, which really acts in the periphery, if your system does carry one of those two, then the anterior wall MI, who's hypotensive, will indicate more likely than not the Levophed to help stabilize this blood pressure and, of course, get the patient into the hospital, rapid transport. Oxygen will be important with these patients as well. Should the blood pressure be elevated, man, that's perfect for an MI because you just start dropping nitroglycerin and then dropping the morphine and such. So those are the big four. The heart, which includes the acute myocardial infarction, and then the two branches, the anterior wall MI or the inferior and posterior wall MI. The pneumonia patient, who's going to have a fact pattern consistent with a immunodeficient patient, which would be your HIV positive patient, your alcoholic patient, or your nursing home patient that has aspirated. Lastly, of course, you could get the chemotherapy patients as well. They're immunocompromised, but I haven't seen that pop up on any of the test bank questions. The next one, the diabetic ketoacidosis, is going to be usually a young female who has not taken her insulin the last couple of days because she's had vomiting, gastroenteritis, diarrhea, the whole shot, and then is altered in her mental status or actually unresponsive. As soon as you see in the fact pattern that this is a diabetic patient, look for the respiration comment that's on there. If it's rapid and shallow, probably non-ketonic hyperosmolar patient. If it's rapid and deep, it's probably Kussmaul respirations, or if they stay the word Kussmaul, then that should point you right to the diabetic ketoacidosis. The beauty of diabetes is just making sure they don't aspirate, so it's going to be really airway control, and that is usually minimal. But the key is going to be to get 2 or 3 liters of fluid into this patient before you can get to the hospital. If you can, at least get 1 liter in, and that should take care of things. Okay. So, anybody have any questions thus far about what the next 2 years, cycle 5, will be on the National Registry exam as far as medical emergencies and the emphasis on pneumonia, stroke, diabetes, sepsis, or heart? Okay, very good. All right, well, I haven't seen anybody raise their hand, so I think we're good to go. All right, let's just take a roll call here. I got Ashley, Daniel, and Tad. Go ahead and raise your hands, all 3 of you. Yeah, let's...
They probably don't know how to raise their hands, but you guys can unmute your microphone for a second and say hi and then unmute it back.
There you go.
Yeah, I don't see the hand raise option, but hi, this is Daniel.
Hi, Daniel. There's Ashley.
Hello,
Okay.
Dr. Frame.
How are you, Ashley?
Good, how are you?
Good, old, ornery, and crabby, same old stuff. Hey, Tad, you there?
Tad texted. He may not have a microphone. He says, yes, sir. He's on the chat room.
Very good. Okay, so let's get started. Can everybody see the screen okay? Yeah, I shouldn't be asking a whole lot of questions here. All right, here we go. So EMS, let's see, vital role in identification, early intervention of life-threatening conditions. Sepsis is really the condition where a patient has compromise to their system such that they're being overwhelmed by either bad inflammation or bad infection. As a result, many of the bacteria that are out there, when it starts to overwhelm the body's defenses, produce a chemical, especially the gram-negative sepsises, the E. coli and the Proteus and some of the other happy stuff that's out there, release a chemical called lipid A. And that's responsible for dropping a patient's blood pressure. It does so because it dilates the vasculature, and it's a very potent dilator. Subsequently, the patient's blood pressure drops. So where do these infections come from? Well, we've been seeing more and more within hospitals as a result of a paper that came out in 2001, but really caught fire in 2012, 2013, when the research that was done by Dr. Rivera had been reproducible in many medical centers. And as a result of that reproducible, the findings were found to be valid. And we started with sepsis protocols, sepsis codes, if you will, and all kinds of other sepsis treatments. And subsequently, it is now sneaked in from the emergency departments and their sepsis protocols to the EMS community. So all you good folks that are out there, out on the field, you're going to run into the nursing home patient that may be febrile and low blood pressure, altered mental status. You could run into the person who was recently hospitalized within the last 30 days, all of a sudden becoming septic at home. The postoperative patient could be becoming septic as well. So there's various scenarios in which a person can become septic. And when we refer to somebody as being septic, we refer to them as having an overwhelming infection, bacterial infection, which cause various physiological changes within the patient, most notably volume depletion, dehydration type symptoms. So you may see some altered mental status, either dehydration causing hypotension, definitely tachycardia. When you start losing more than 10%, 15% of your volume, you start getting tachycardic. When you start losing more than 25 to 30% of your volume, you're going to start getting hypotension. With the hypotension, of course, comes the altered mental status. And that's usually when you get the phone call from family or from nursing home that, hey, they're not their usual baseline. We really need to take a look at this person, or this patient's got a 101 temperature and altered mental status. Septic shock, the classic sign of shock, high blood pressure, low blood pressure, high respiratory rate, altered mental status, fever, still stands. So whether you apply sepsis or septic shock, it's really going to depend on the support that the vital signs give you. So within the state of Texas, an average EMS transports 2 to 3 patients with severe sepsis a day to local emergency departments. I'll bet that number is probably closer to 20 to 30. But in our local region up here at our hospital, we get at least 2 or 3 a day. Now, when you give antibiotics, the faster you give the antibiotics, the better the chance you have of survival. So when a patient comes in, obviously with a low blood pressure, the opportunity to help these patients was actually in the field. So your first objective out there is to get the blood pressure back up again. If you can get them out of a shock state, then we can kind of stem the tide, at least for a little while. Once the patient slips into shock, we've got probably a better than even chance of losing the patient in the hospital. But as you should know, that 2 hours, 15 minutes it takes for the emergency department to identify and treat a septic patient in the hospital. The protocols now and the sepsis goals and such tell us that we should have antibiotics started within that 2 hour and 15-minute window, although many of us strive for immediate, especially if you're dealing with meningococcemia in a child, where the antibiotic has to be administered within 30 minutes of arrival to the emergency department. Now, that's arrival to the emergency department. I don't know how long they've been ill at home. I don't know how long it took for the patient to get to the hospital by EMS transport. And subsequently, that 2 hour and 15 minutes does not start when the patient hits the door. That 2 hour and 15-minute really starts at the time that the phone call is made to EMS. And again, if the patient's been sick for 2 or 3 days, you know, that number could be well down. For every hour that you delay antibiotics, you get an 8% increase in the number of septic patients dying. But the converse of that, the sooner the patients are given antibiotics, the better the outcome, with an 8% decrease in patients dying per hour. That's an incredible statistic. So our metrics are simple: fluids, antibiotics, right away. You guys out in the field, you do the fluids. Us guys in the ER, we do the antibiotics. Everybody wins. Without your fluids in the field, these patients are going to die anyway, because shock in of itself, whether it's caused by sepsis, hemorrhagic, neurogenic, cardiogenic, and such like that, shock in of itself kills over half the people that are out there. The body cannot sustain a shock situation for more than a few hours, and then they die. And again, you guys get on the scene, you don't know how long they've been like this. So if they've been this way for 2 or 3 hours, hell, you know, you're already in the 30-35% range of death anyway. So hospitals worldwide have scrambled to really implement these protocols after that paper that came out. And the markers used for these types of patients in the field mostly has to do with vital signs and their history, whereas the markers that we use in the hospital and such, we start infusing blood, inotropes, and give lots and lots of fluids. Sometimes we even drop a central line to measure their pressure. Someday, hopefully within the next 10 years or so, we'll have the paramedics in the field trained to do exactly that, dropping central venous pressure, or have some sort of technology in place where you can put it in the patient, whether it's by injection or just waving it over their heart, whatever Star Trek kind of stuff you're watching out there. And you can determine what the central venous pressure is and then guide your fluid therapy from that. The only thing that you have to guide your fluid therapy right now is blood pressure. So a good metric is going to be, did I correct the blood pressure? Did I correct the pulse? Now, typically these patients are not bleeding to death. So giving these patients 2 or 3 liters is not unheard of. And if you're in one of those systems, folks, that are out there in some of the states like Oregon or maybe Maine, where transport times can be 2, 3, 4, 5 hours, having 3 or 4 liters of fluid in these patients is not a bad thing. Now, contrast that with the trauma patient, where we really want you to maximize your liter infusion to 2 liters. And even then, if you get to a map of 60 with a systolic pressure of 80 or 90, you can do permissive hypotension. It doesn't exactly work that way with septic shock. Permissive hypotension, there's no such thing in the shock patient secondary to sepsis. These are infections that are overwhelming. They're getting vasodilation. You're not going to hemodilute them so much where they're going to run the risk like they do with trauma, where the bleeding is not controlled because it's all internal. Septic shock patients very rarely are bleeding. Subsequently, giving them, again, 2, 3, or 4 liters is not unheard of. Although once you start getting over 3 liters, you kind of sort of want to be in contact with a hospital and such. That 4th liter, especially for older patients, can throw a patient in congestive heart failure pretty quickly. In any event, back to where we were. Let's see, we looked at follow-up studies. We looked at protocol care and such like that. We look at high-quality sepsis care provided without invasive monitoring. And so we're back to the emergency department where we're doing cardiac monitor, blood pressure readings, and we're drawing blood to see what their lactic acid is. There are EMS communities now that are out there that are actually have iStats on their ambulance where they can draw off electrolytes and lactic acid. The lactic acid is going to be an important guide for you to determine whether or not you're making an impact on the hypoperfusion. Lactic acid can or cannot be sometimes produced by the bacteria. We're not worried about that. When you hypoperfuse, in other words, a shock situation, 80 blood pressure, when you hypoperfuse tissue, what happens? You get the production of lactic acid. that lactic acid can now be directly measured and is in direct proportion to the severity of the infection, as well as the length of time the patient's been hypotensive. So let's say you get on a scene and you pull off a lactic acid on these patients, and this is just an example. You're not going to get this on the exam, but here's your example. You draw off this patient and you notice they've been hypotensive for about 4 hours. Their lactic acid is 5 or 6, which is pretty high. You drop 2 liters of fluid into them. About 15 minutes outside the hospital, you draw off the lactic acid again, and now you're down to 3. Well, in that time, you've probably improved this patient's survivability by 30%. I mean, it's pretty impressive as you're starting to clear the lactic acid even further a couple hours down the road. You'll see if these patients have a completely survivable condition. That was just with the fluids. Once you get into the hospital, of course, I can put the antibiotics into them. And at that point, we can put them in the intensive care unit and continue with the great therapy that you started in the field. Again, of the 5 conditions that are going to be tested on medical emergencies for the next 2 years, sepsis is one of those conditions. And we want sepsis management to be part of the EMS system insofar as the proper treatment of sepsis or worse, septic shock. Even the septic patient may have a normal blood pressure, but a high heart rate would require 1 to 2 liters of fluid. By the time I get them in there, if you're not measuring lactic acid, my initial lactic acid is going to reflect what you've done within the first couple of liters on these patients. It's going to be something that you'll see on the ambulances, hopefully within the next 5 to 10 years as we start putting iStat machines into the boxes, training each and every one of you on how to read electrolyte panels and lactic acids and troponins, especially for the heart patient. So let's look at a couple of things. During the first 4 hours, the volume of intravenous fluids required for the sepsis patient is between 2.8 to 3.33 liters of crystalloid. So like I said, between 2 and 3 liters, around the 4th liter, then, on the older patient, we may start running into problems. Certainly on the 40-year-old kidney patient or the 18-year-old pyelonephritis patient who didn't take her antibiotics, who just happens to be pregnant, once you start getting around that 4th liter, you can again start running with congestive heart changes insofar as the patient's heart has been affected by the sepsis now and cannot pump anymore. When that lipid A gets released into the body from the gram-negative bacteria that's causing the sepsis, it can dilate the blood vessels. The heart is starting to pump its little heart out, excuse the pun, to try and keep the blood pressure up. But if that sepsis is allowed to go for too long, and that lipid A is allowed to now get into the heart and such, it's going to cause a decompensated heart failure. It's going to cause cardiac contractility to go way, way down. And subsequently, even a younger patient can get in a CHF situation. So we like to sit around the 2 to 3 liters by the time you get to the hospital kind of thing. And if you get into a situation where you're over 3 liters, you may want to give one of us a call to see if the 4th liter is going to be indicated. This is where real close assessment every 5-minute vital signs are essential, but you have to be listening to this patient's lungs a lot. Non-rebreather masks a lot. Keep their oxygenation up. Don't worry about some of the stuff that you're hearing out there about the deleterious effects of oxygen on patients. Trust me, for the first 30 minutes, it ain't going to kill them. Okay? We'll handle the oxygen when the patient gets into the emergency department. I have blood gases and everything else that I can do with all that stuff, and I can fine-tune the oxygen at that time. I'm not worried about the first 30 minutes. You can pour whatever oxygen you want to into them. All right, so the crystalloids were the predominant fluid used, administered 96% of all patients overall. You may ask, well, what's the other 4%? Well, blood products in the patients who definitely have congestive heart failure, patients who are anemic. We use sometimes albumin in patients who have various types of pulmonary hypertension or cardiac failure, diastolic failure specifically. There's all kinds of other things that we use. In the field, albumin and blood out there If they are present out there, they're probably for the trauma patient only, and they're not quite readily accepted for initial field stabilization. So what you'll get on the National Registry exam is 2 to 3 liters of fluid. That's it. We're not going to worry about blood or albumin or all the other happy stuff, starch and some of the other happy stuff that's out there we use in the hospital to maintain sepsis control. Now, you can tell the last paragraph there, the last statistic, is that if you get 1 to 2 liters of fluid, the chances of me having to use pressors in the emergency department to keep the pressure up is reduced by 5 to 6%. That's the number that you see in there, 12 to 20. So in this particular case, the faster you correct the shock for us within the 1 to 2 liter, 2 to 3 liter limit, the better it's going to be for the patient. And if I can avoid at all putting Levofed or dopamine on these patients, which the advantage of those 2 medications is acting at the periphery of the vascular system to increase blood pressure. When you get an epinephrine or dobutamine and such, those are direct acting on the heart, and they really cause the heart to work hard. In a young sepsis patient, that may not be bad, but I don't know any EMS system that's carrying dobutamine or epinephrine drips. So most of the systems that have dabbled in vasopressors have dabbled with dopamine or Levofed. All right, very good. Okay, so 2 liters, 20 to 30 milliliters per kilogram in these patients once sepsis is identified. 20 to 30 milliliters per kilogram is what you want to administer within the first hour. Okay, so if your patient weighs 100 kilograms, then 20 times 100 is going to be 2,000. There's your 2 liters. If the patient weighs 75 kilograms, there's your 1,500 cc's in the first hour. So that's 1.5 liters in the first hour. Trust me, you're not gonna be outside the limits. 30 is the upper limit of that normal. We use 30 per kilo if the patient's hypotensive to start with and continues to be hypotensive. So for the 100 kilogram person, the 30 per hour, 30 per kg per hour. Could very well result in 3 liters. And you'll be perfectly safe and within all protocols to do that. Just be careful after 2 liters, after the 3rd liter and such. I'm sorry. Just be careful after the 3rd liter. Make sure you're in contact with one of us so that we can authorize the 4th liter. Children. If you get a child that's septic, let's say you got a chemotherapy child, leukemia or any kind of cancers where they're receiving chemotherapy and they become septic. Some of those children receive 60 milliliters per kilogram per hour in the first hour or 2 hours. We usually hit up the kids pretty good because we know that their hearts are pretty darn strong at that age. Even if they're weakened a little bit by chemotherapy, they do a lot better than a lot of adult hearts. And subsequently, we can go with a little bit higher dosage. So 60 milliliters per kilogram is not out of the realm for a pediatric patient. You won't be tested on that. Stay within the 20 to 30 and you'll be safe, but it's going to be for the first hour. So getting 2 liters into a patient over 1 hour is probably about most what EMS systems are going to have to do before they arrive at a hospital. But again, from some of you who may be in the rural areas of this country, you may start getting into extended protocols, in which case you have to be thinking about the 1st, 2nd, and possibly even the 3rd hour. Many of these patients, especially those who are younger patients and such, may deserve a little helicopter ride, a little air ambulance ride to get them someplace a little bit sooner if they're showing you signs of sepsis. Okay, so tachycardia greater than 90, tachypnea greater than 20, temperature greater than 100.4, or hypothermia below 96.8, or signs of poor perfusion. So your EtCO2, when you drop the tube on these patients, maybe 25. If you got one of those fancy nasal cannulas that's got the EtCO2 on it and you're less than 25, with the systolic pressure less than 90, or a MAP less than 65. Those are your criteria. This slide deserves memorization. If you're going to be taking the National Registry exam anytime in 2019, 2020, this slide will be part of that. This was the slide that was presented to us as part of those of us who write questions for the National Registry. How do we figure out questions based on the criteria of the recognition of sepsis based on this slide published by the American College of Emergency Physicians? And the answer is, I don't know yet. But I would suspect that since we're very big on technology, and we love to see EtCO2s emphasized everywhere, including after intubations, that last statement there is going to be probably the most prominent of the questions detractors are going to be stated. So for instance, a question comes up with a patient who's presenting with a tachycardia of 120 and a tachypnea 30 per minute, the temperature is 102.5, and his blood pressure is 70 systolic. Choice A, choice B, choice C, choice C. Is your EtCO2 less than 25? Is your blood pressure less than 90? Do you have tachypnea or tachycardia? The last statement there is probably going to be, what's the most reliable signs that this patient's in septic shock? And it's going to be the last statement there. Why? Because it's technology based. In other words, an EtCO2 measured, systolic blood pressure measured, heart monitor showing a tachycardia measured. Those are going to be the three big ones because we're big on technology based. And subsequently, we like objective data, and those are about the most subjective that you're going to get. Tachypnea still has to be measured by counting 1, 2, 3, 4, 10, but for the most part, we like the last statement. Okay, so the second bullet point here, systolic pressure less than 90 or mean arterial less than 65, indicates distributive shock. Now, they're going to ask you on the exam, depending on what cycle or what test bank questions you have right now, maybe even as part of your adaptive questions, they're going to ask you, a septic shock patient represents what kind of shock? And there's going to be cardiogenic, distributive, hypovolemic, diabetic. There's going to be BS answers. One of them is going to be hypovolemic shock. One of them is going to be hemorrhagic shock. There's going to be a distributive shock, etc. So when you think sepsis, you think distributive. When you think distributive, you think sepsis. Hypoperfusion based on vasodilation of that lipid A chemical that I was just telling you about. It's not hypoperfusion because you lost fluid. It's not hypoperfusion because your heart has failed and can't pump, like you see in cardiogenic shock. It's not hypoperfusion because you're bleeding to death, like in hemorrhagic or hypovolemic. It's not dehydration as a result of heat exhaustion or heat stroke. This is a chemical that's released into the body and you get distributive shock. Contrast that with anaphylactic shock. We call it anaphylaxis because even though you get the vasodilation, and it's not due to pump failure or anything like that, the mechanism tells us in this particular case that it's anaphylaxis causing this, and the treatment's going to be much different. Antihistamines for one, epinephrine to get the vessels to constrict and the bronchioles to dilate. Contrast it with sepsis, where if you give them a shot of epinephrine and such, it's probably not going to do a whole hell of a lot. Why? Because when antihistamines are used in anaphylaxis, it counteracts the histamine effect, which is a vasodilator. Whereas the distributive shock, the so-called vasodilation as a result of lipid A, can only be reversed with the use of vasopressors and with antibiotics killing the bacteria that's producing the stuff to begin with. So we classify anaphylaxis perhaps as a distributive shock, but it's its own animal, anaphylactic shock on the side. We discussed that in different terms. Distributive shock is exactly that. It's affecting the entire system, and it's a distribution of lipid A throughout the entire body, affecting all the vessels. Okay, so when you get a lactate level of greater than 4, it means that there's not enough fluid getting into the muscles, bowel, brain, heart, kidneys, everywhere. It's not enough. And subsequently, lactic acid's produced as a byproduct of the anaerobic metabolism. Subsequently, the lactate goes up. And if anybody's ever had a muscle cramp in their life after exercising, it's because you haven't cleared the lactic acid from your muscle. Subsequently, you push fluids on yourself and you finally get that lactic acid washed out. Well, imagine lactate increasing in a patient 4, 5, 6, 7, 8. I've seen as high as 20, where these patients are really, really septic or hypoperfusing for a long period of time. So we use 4 as the breakoff. So the second paragraph there, and then the third paragraph there, very important as far as monitoring and such. Again, if you don't have iStats, the 4 lactate will come to you in the years to come as we put machines out into the ambulances that can help us measure this stuff. So what do we use in the meantime? Well, we're going to use some backhanded technology here. So plug in your EtCO2 on all your patients where you suspect sepsis. Because as you can tell from the 4th and 5th bullet points here, if lactic acidosis, if direct serum lactate levels are not measurable in your ambulance, then put the EtCO2 on them. And you can see that decreased end-tidal CO2 correlates with elevated lactate levels. Most commonly, an EtCO2 of less than 25 will give you the sepsis indication that you're looking for. So tachypnea, again, big one, but we like technology. So put an end-tidal CO2 on these patients, and if you got a level of about 20 or so in a patient with a 101 temperature with shortness of breath and difficulty breathing, you've got yourself probably a sepsis patient with secondary pneumonia. If you've got a patient who's been treated on antibiotics recently and is presenting like this, well, their lungs would probably be clear, but their kidneys could be shot. Or if they've got a bad cellulitis someplace, somewhere on their body. These are all good ways to be picked up by your EtCO2, and you can actually see, is this a hypoperfusion state as a result of sepsis, or is this something else? And all it's doing is just putting another indication for you out there that sepsis could be at play. Okay, so to wrap it up, this was a short one, but short and sweet because I'm planning on emphasizing all 5 medical emergency conditions over the next several roundtables. We want to review the heart and, of course, pneumonias. Pneumonias as they relate to respiratory failure and difficulty breathing and such like that. And then, of course, the diabetic ketoacidosis patient, the stroke patient. We certainly want to hit all 5. Today I hit sepsis because it's kind of near and dear to everybody's heart in the emergency department. And also, we've had a number of sepsis deaths that should not have happened, but for the lack of attention by our paramedics in the field to a hypoperfusion state as a result of an infection and not addressing the fluid needs appropriately. So fluid resuscitation is aggressively initiated. I may ask you to give the patient cytomedrol or Decadron. Now, you might say to me, well, Dr. Frame, doesn't that suppress the immune system? It does. Over a period of 24 to 48 hours, steroids will suppress the immune system. But what it does within 10 or 15 minutes is it substitutes for the steroids that are supposed to be getting released from the adrenal glands to keep the blood pressure up. So I'm going to ask you to give the steroid in the field, help get the blood pressure up, or at least start us on the way of getting our blood pressure up, because I prefer steroids over vasopressors. Start getting the blood pressure up. And once I get the antibiotics in, I can taper the steroids. But once the antibiotics are in, I can kind of take over for the immune system here. So if it is transiently suppressed by a day or two worth of steroids, I've got the antibiotics in place to kind of pick up for all that. And then I do a taper of the steroids so that the patient can maintain their own blood pressure. But don't worry about immune suppression by steroids in the first day. I need that steroid on board to get that blood pressure back up so I can get these people out of septic shock. And then good things come from aggressive management and such. So subsequently now, that's a quick down and dirty on sepsis. It is everything that's in here is everything that's been given me by the National Registry. This is the only slides that will ever have any information on it that you will need for sepsis. So don't get into these big 50-page books to worry about how do I manage sepsis, and more importantly, what's going to be on the National Registry. Everything in this slide presentation that you see is the material in which the questions will be drawn from. Nothing outside of this. Know the slides, you'll know the sepsis, if that appears on your exam. Does anybody have any questions at all? Well, Jane, sounds like everybody's got a good handle on this.
We're done okay? We're done already? How did you manage that in less than an hour?
Yeah, really. Yeah, I get a little chatty sometimes, but sepsis kind of kept me under control here a little bit. So there wasn't a whole lot to say, and there's only so much a BSer can say in an hour. So there we go.
Okay, well, thank you very much, all. I hope you all have a Merry Christmas, and we'll be seeing you all soon. Thank you, Dr. Frame.
You're most welcome. You guys take care.